Hassan, do you have anything else to add?
Yes دكتور, if you please. ممكن نسألها كمان عن ال past surgical history, مثلا إذا عملت DNC أو أي procedure يعني including her reproductive system.
Okay, so that's very good. If there is any recent instrumentalization of the uterus, that would be important. Samah?
If there is dysmenorrhea or dyspareunia.
Of course, whenever a lady presents with any abdominal pain, you should ask her about history of dyspareunia and dysmenorrhea. Philip? Okay, looks like Philip raised his hand by mistake.
Yeah, بالغلط خليتها.
Okay. So, just to save time, let's proceed. So, as we said, we should analyze the pain. We all know how, how analysis of a pain complaint should be with the acronyms CRATES. We should also analyze whether this pain has any relationship to menses. And when does it start? Is it either increased or relieved during menses? We should ask her about all the GI and genitourinary symptoms, especially focusing about if there is any history of discharges, any history of dyspareunia, any cyclical bloating, if she had any similar episodes previously, and if there were, how were they treated or diagnosed? We should analyze her gynecological history, especially if she has any Mittelschmerz, how were her cycles, and history of STIs, contraception, and which contraceptive is she using, if any. How were her pap smear done, and when was her last pap smear? We also should ask in gynecological history about any history of intermenstrual bleeding and postcoital bleeding. And then, as always, we just have to outline our obstetric history. So that's a summary of what your colleague said. So after we interviewed her, that's a summary of her complaints. Her pelvic pain is colicky and suprapubic. It's not associated with any radiation or shifting. She reports it to be when it's at the worst, 7 out of 10. The pain occurs at any time of the menstrual cycle, but it's usually worst with menstruation. The pain could also be worse when she passes urine or opens her bowel, but there is no relationship to exercise. She reports painful intercourse, especially for the past 2 years, and she was worried she might be having an ovarian cyst or other gynecological problem. The pain occurs nearly during every intercourse, unless the penetration is very, very gentle, and she has never been diagnosed with any sexually transmitted infections before. She also reports some thin vaginal discharge that has been present for the past 5 months. It's not odorous, and she has not sought any medical attention because it did not bother her before. She also has some dysuria, no fever. She has no other significant GI symptoms. She had a history of lower UTI and was treated with antibiotics. There is no medical or surgical history of note, and she's not on medications. She conceived twice, and she delivered both times via normal vaginal delivery. She's currently using OCPs and has been on them for the past year. She was previously using male condoms, but she switched to OCPs. So I'll give you a moment to let it sink in before we proceed. So, in cases of vaginal discharge, what should be our differential diagnosis be? Abdullah?
ممكن دكتور ectopic pregnancy.
With vaginal discharge? I'm not discussing this case in specific. I'm saying what's your differential diagnosis for any case with vaginal discharge? It's a general question. Layth?
Vaginitis.
What type of vaginitis?
Bacterial vaginosis.
So it could be bacterial vaginosis. Does anyone have anything else to add? Sarah?
ممكن pelvic inflammatory disease.
Okay. Fair enough. Does anyone else have anything else to add? Abdullah?
لا دكتور رفع ايدي من المرة الماضية.
Okay. So does anyone have anything else to add in regards to which be our differential diagnosis in general if we have a case of vaginal discharge? Okay, urinary incontinence, but we'll put it down low in our differential diagnosis. Samah?
Maybe if there's foreign body or irritants.
Okay, especially in younger women. It could be a foreign body. What's a very common foreign body? مين بس اللي عم بحكي هلا؟
يزيد.
اوكي يزيد لو سمحت بس ترفع ايدك عشان ما نحكي فوق بعض اعرف مين اللي بيحكي. المرة الجاي.
اسف.
اوكي تفضل يزيد.
في عندي شيئين يمكن vulvar dermatitis او physiological discharge.
Okay, vulvar dermatitis usually is associated with pain and pustules and lichenification, but it's not associated with discharge. Okay? So lichen planus, vulvar dermatitis are beyond your scope as GPs, but in general, they're just like the dermatosis you've discussed in your dermatology rotation. So lichen planus and lichen sclerosis and contact dermatitis, and rarely it could be squamous cell carcinoma of the vulva, but in general, they usually are not associated with discharge, with at least vaginal discharge, and they're usually involve more the perineum than the vagina. Philip?
دكتور على جواب سؤالك ايش اكثر foreign body كنت بدي احكي tampons.
Yeah, it's usually tampons, especially although they're rarely used in our area, but some ladies do use tampons to control their menstruation, and sometimes pieces of these tampons or a whole tampon could be missed, and it will produce a very foul vaginal discharge. Okay, Abdullah, do you have anything else to add in regards to a differential diagnosis for a vaginal discharge?
دكتور ممكن tube ovarian abscess. إذا صارت chronic PID.
We're not discussing PID at this moment. Okay, don't fixate yourselves about PID. We're discussing just vaginal discharge, and I'm not asking for a differential diagnosis for this case per se. So in general, Hamza, do you have anything else to add?
دكتور ممكن endometrial cancer or endometrial hyperplasia?
No, they do not present with vaginal discharge. They can present with abnormal uterine bleeding, and that would be blood, not discharge. Okay. Ruba?
دكتور ممكن candidal infection?
It could be vulvovaginal candidiasis. Yes, it could be. So our differential diagnosis, most commonly and very commonly and usually unnecessarily treated, it could be physiological discharge. Physiological discharge is non-pathological. It's usually not that bothersome. It usually increases with pregnancy or just before menstruation, and it's always not foul and very thin. And it's not associated with other symptoms. It could be bacterial vaginosis. It could be vulvovaginal candidiasis. These are the second two more common causes. Could be any of the STIs, whether trichomonas, chlamydia, gonorrhea. It could be a cervical lesion. Cervical lesions can present either with abnormal uterine bleeding or thin vaginal discharge. More commonly, it's ectropy, but it also could be a cervical polyp. And lastly, it's a foreign bodies. Foreign bodies are especially common in toddlers, but also sometimes in younger women in their second decade of life when they miss a tampon. So that's in general in regards to vaginal discharge. After our exam, we'll discuss the differential diagnosis for our case specifically. So what should we perform during our examination of this lady? Of course, ideally we should perform a complete physical exam, but in most cases, we have to ration our time to try to see as much clients as possible. So what are the most important aspects of our physical examination in this case? Abdullah?
دكتور ممكن speculum examination.
Okay, speculum exam is quite important. Try always, guys, rational when you answer questions. Try to go from the least invasive and the more general to the more specific and more invasive. Okay, just as a general concept in medicine and for your answers. Hassan?
Doctor, we can do abdominal exam just to follow with her pain to make sure if there is tenderness or masses or something like that.
Okay, so you're doing an abdominal exam for tenderness and masses. Very good. Does anyone have anything else to add in regards to our examination in this lady? Sarah?
دكتور ممكن by manual examination لليوترس.
Okay, bimanual examination. What are you looking for during bimanual examination in this case? What findings are you trying to either prove that are present or absent?
ممكن نشوف إذا اليوترس fixed or mobile.
Okay, very good. Is there anything else that's important?
إذا في palpable masses.
Okay. Would you like to add anything else before we go to your next colleague?
لا دكتور.
Okay. Samah, do you have anything else to add?
دكتور بالنسبة للبايمانوال exam, I think we do it also for exclude cervical excitation.
Yes, cervical excitation is one of the most important findings during our bimanual exam. That is correct. So Abdullah talked about speculum exam. What are we looking for during speculum exam in this case? What should we report during our speculum exam in this case? Hassan.
دكتور ممكن زي ما حكينا بالديفرنشال دايجنوسيس إذا في polyps أو مثلا lesions بالcervix أو
Okay, that's very good. Is there anything else?
ممكن laceration ممكن.
Lacerations will not cause discharge. They will cause bleeding or pain.
Inflammation يمكن.
Okay, Abdullah. It was your suggestion after all.
دكتور الفاجينال ديسشارج بنشوف الكلر تبعها بنشوف الكونسستنسي الأودور ممكن.
Okay, so you're commenting about the vaginal discharge, whether it's present or absent. And if it's present, you should describe the character, the consistency, the color, the smell, and from which side is it coming from? Is it just coating the vagina? Is it coming through the cervical os and so on? That's very good, Abdullah. So as always, we do general inspection and vital signs because fever is quite an important finding in this case, although in a case where she had her pain for 2 years, we doubt there will be any fever associated with it. Yazid, would you like to ask something else?
دكتور بنعمل بعرفش اذا حكوها دكتور انا مش منتبه بنعمل انسبكشن بنشوف اذا في اي signs of excoriation او inflammation erythema edema swallowing.
Okay, so you're inspecting the cranium, in other words.
Yes, the genital area in general. Yeah.
Okay. So inspection is always a part of speculum exam. Sometimes you don't focus on it, but always before a speculum exam, ideally you should inspect the cranium for any swelling, lesions, or excoriation. So the abdomen, we examine it mainly for masses and tenderness in this case. We should do a pelvic exam in regards to the speculum and bimanual exam, and we'll discuss the findings later on. So any questions before we proceed to our examination findings? Okay. After performing our exam, the patient looks well. Her vital signs are all within normal limit, and the abdomen is soft lax, not distended, with no organomegaly. There were no masses palpable, but there is suprapubic tenderness. The speculum, on the other hand, shows normal smooth vagina with a gray-white colored discharge. It's thin. The uterus is undiverted but fixed, immobile, and it's tender to movement. Otherwise, it has a smooth outline and is as expected to be in regards to size. In regards to the adnexia, there were no adnexial masses, but the adnexia were tender during palpation. Are the findings clear? Does anyone have any questions in regards to these findings? Okay. So as always, after performing our examination, we should start investigating to confirm what our differential diagnosis. But before we start with describing the investigations, just give me a moment. We should discuss our differential diagnosis. So I'll give you a summary of our findings so far. We have a 28-year-old gravida 2 para 2. She has an abdominal pain for the past 2 years, which increases the menstruation and is associated with dyspareunia and a thin vaginal discharge and dysuria. Her abdomen is soft lax, but she has suprapubic tenderness. The uterus on bimanual examination is fixed anteverted with cervical excitation and adnexial tenderness. So, what should we put down as a differential diagnosis? Yazid? Yazid, you raise your hand. Okay, Hassan, go ahead.
دكتور ممكن يعني واضح انه ممكن نحط البي اي دي in the differential diagnosis وكنت بدي اضيف كمان as she had suprapubic pain ممكن cystitis.
Okay, so it could be cystitis and it could be PID. Very good. Abdullah, do you have another different set of differentials to add?
دكتور بما انه الفاجينال discharge gray ممكن تكون bacterial vaginosis.
Okay, but does vaginosis cause abdominal pain or dyspareunia or dysmenorrhea?
No.
So it's not a very good differential diagnosis then, is it? Of course, our differential diagnosis do not have to fit every single symptom she has. We just order them according to which is more likely than others. Hassan.
دكتور ممكن ovarian cyst أو complicated ovarian cyst.
Now, an ovarian cyst would not present with chronic abdominal pain for 2 years. And it would not present with vaginal discharge, nor would it present with dysuria or dyspareunia, or the pain, and the pain would not be related to menses again. Could
Yes.
there be an ovarian cyst? Yes, there could be, for multiple reasons. But let's change the case slightly. Let's say this lady has her abdominal pain for the past 2 days, and she's slightly febrile. Would it change your differential diagnosis? Would you like to add anything else to our differential diagnosis? Abdullah? أنا زريدة. Sarah?
ممكن UTI.
So I already said that UTI is part of our differential diagnosis from before. Of course, UTI can be feverish if it's an upper urinary tract infection, and could be without fever if it's a lower urinary tract infection. Ruba?
دكتور ممكن اكتبك pregnancy.
Yeah, we should always try to rule out ectopic pregnancy in an acute abdominal pain. What else should we rule out? She's a lady in her second and third decade of life. Sarah?
ممكن appendicitis.
Yeah, there could be appendicitis. That is correct. So our differential diagnosis changes according to the duration of our symptoms. Okay, it's not just the presented complaint, it's the duration. I'm sorry, I'm gonna have to go. I'm sorry. So let's go back to our investigations. What should we do to confirm or rule out any of our differential diagnoses? Hassan.
Doctor, we can do urine analysis and culture.
Okay, fair enough. Hassan is suggesting urine analysis. And I agree. Does anyone have any other suggestions? Sarah?
نعمل بيتا HCG عشان نشوف إذا في ectopic pregnancy or not.
Okay. If you're in doubt, you could do beta HCG, but why wouldn't I do beta HCG in this case? Do you remember her history? She's on OCPs and her cycle started less than 10 days ago, and it was regular, it was normal. So it's quite likely for her to be pregnant. And even if she was pregnant recently, or it's impossible for her to be pregnant because she did not ovulate yet in general. So I wouldn't do beta HCG in this case. Ruba, do you have any other investigation you would like to add?
لا دكتور.
Okay, Abdullah.
دكتور ممكن نعمل نيتروزين بيبر مثلا للفاجينال discharge أو KOH preparation مثلا.
Do you know what we use nitrazine paper for?
النيتروزين دكتور عشان الPH. شوف قديش الPH تبع الفاجينا.
It's usually when we use that term, it's for premature pre-labor rupture of membrane. Okay. So try to refrain from using. If you want to say it, just say it frankly. I want to test the pH of the vaginal discharge, and that will be very good. Although we rarely do it anymore. Does anyone, Hassan, do you have any other investigations you would like to add?
Of course, دكتور. ممكن نعمل CPC إلها. ممكن نعمل vaginal swab كمان.
What type of vaginal swab?
ممكن to check for gram stain or culture.
Okay, fair enough. So in general, CPC is not that important, especially that the patient's not febrile. And she did not present with an acute presentation, so her leukocytosis, I presume you chose CPC for leukocytosis, so leukocytosis will not be relevant in this case, neither would be ESR and CRP. But in general, we should perform what we call a high vaginal swab for culture and gram stain microscopy. we should do nucleic acid amplification tests for chlamydia and gonorrhea. Remember, our top differential diagnosis was PID. She has an abdominal pain and the uterus is fixed, so we should do an ultrasound to try to figure out if there are any other genitourinary lesions on ultrasound. Now, ESR, CRP, and CBC, I would do them if the lady presented with an acute presentation or her presentation with us was associated with fever, but not in general, not for every single case. Yazid, do you have something to add?
دكتور طب ما بنعمل اندو سيرفايكال سواب ليش هاي فاجينا ليش مش ناخذ الاثنين مثلا
I'll discuss them later on. Okay.
تمام دكتور.
Okay. So we performed our investigations and these were our results. Just go over them, read them thoroughly. I'll give you a couple of minutes to read through them before we discuss them and discuss our differential diagnosis. So does anyone have any questions in regards to these findings before we proceed? تفضل فيليب.
دكتور هون الباست سيلز do we mean neutrophils ولا شيء ثاني؟
Yes, we mean neutrophils.
Okay, thank you.
You're welcome. Any other questions? In general, pus cells means polymorphonuclear cells. These are activated neutrophils. They're not just a normal type of neutrophils that are present in your bloodstream. So we discussed our differential diagnosis from before, but right now, what's our most likely differential diagnosis? Hassan, تفضل.
دكتور STI.
So you're going for a sexually transmitted infection. What type of sexually transmitted infection are you going for?
Because she has positive test for chlamydia trachomatis.
Okay. So in general, sexually transmitted infection just means it's a bacteria. It's an infection that's transmitted via sexual contact. But when we want to reach a diagnosis, we should specify whether it's a PID, a cervicitis, a vaginitis, a urethritis, conjunctivitis. These all could be sexually transmitted infections. So Philip, what would you try to complete his answer? What would you say?
I'd say chronic PID.
You'd say chronic PID. And what's the etiology? What's the causative agent in this case, most likely?
Chlamydia.
Chlamydia. So what I would say, it's a chlamydial PID. You can try to be more specific and say it's subacute or chronic. That wouldn't hurt issues, but in general, try to be specific. So do you guys understand what's the difference between PID and vaginitis and cervicitis? Would anyone care to tell me what's the difference? Why sometimes we use the term vaginitis while other times we use the term PID? Philip?
I guess difference هو location اللي هي upper أو lower.
Upper, what do you mean by upper?
upper اللي هي من cervix وفوق. lower من cervix وتحت.
Okay, very good. So whether it's involving the endocervix and higher, so the endocervix, the parametry, and the tubes, that's a PID. If it's lower than that, that's not a PID anymore. How can we differentiate between whether it's PID or not clinically? Both are associated with vaginal discharges, but what if the lady complains of pain, if there is any tenderness on examination, if there is any signs of adhesions, just like the immobile uterus during our examination, if she's febrile, these all suggest that it's a PID rather than being a cervicitis or a vaginitis. Okay? And that's important because it will change our management. So this indeed is a PID. So going back to Yazid's question, what's the difference between when we say a high vaginal swab, a vulvovaginal swab, and an endocervical swab, or an endocervical swab? Does anyone understand the difference? Okay, so in general, it depends on what are we trying to detect in the first place. If we're trying to detect bacterial vaginosis or candidiasis, and rarely trichomonas, we do a high vaginal swab. In a high vaginal swab, we obtain a swab from the discharge and the area around the fornices of the vagina. We send it for analysis and microscopy. The lab will stain it. We'll use KOH and we'll use a wet mount. They'll count the number of epithelial cells, the presence and absence of trophozoites, the presence and absence of spores or hyphae, and then they will stain it and tell us whether there are clue cells or there are no clue cells. If we're trying to detect a sexually transmitted infection, more specifically chlamydia and gonorrhea, we swab the area on the lower vagina and we send it for what we call nucleic acid amplification test. That's how we diagnose these infections. Now you'll see in some books, they use endocervical swabs for the same purpose. Okay, that's why I wrote or endocervical swabs. And previously I did not specify what type of swab. Vulvovaginal swabs and endocervical swabs are used for the same purpose, which is to detect sexually transmitted infections using nucleic acid amplification tests. Although currently it's deemed that vulvovaginal swabs are more sensitive than endocervical swabs and they're the ideal treatment. But your book does say endocervical swab, so I will accept both answers. Is it clear, Yazid? Did I answer your question?
Yes, شكرا كتير غلبتك.
No. Okay, so any questions so far before we proceed? سماح تفضلي.
دكتور هلا اللي كان بوزيتيف ولا تروخوموناس صح؟
Yes. لا مش تروكوموناس. كلاميديا. تروكوماتس.
لا يعني قصدي أنا بالتست NAS تست.
Yes. كلاميديا تروكوماتس.
هي برضو بارت منها يعني.
Yes, it's part of nucleic acid amplification test.
تمام.
Whether it's chlamydia or gonorrhea, these are mainly done by nucleic acid amplification test. Nucleic acid amplification test is just like PCR, but the difference, instead of giving primers for multiple parts of the DNA or the RNA, of course these are bacteria, so they're DNA, they give primers that are just specific to these types of bacteria. So if there's any part of this bacterial DNA, it will be amplified and detected. And it's very sensitive. It's around 96% sensitive. So in general, what are the risk factors for this etiology, for this pathology, sorry? Sarah?
دكتور إنه multiple sexual part ممكن نالي
سوري
بارس.
سارة صوتك عم بقطع، بس ممكن تحكي شوي وتعيدي اللي حكيتيه؟
دكتور ممكن إنه previous surgical procedure.
Such as? And if she did an appendectomy, that will be a risk factor for PID.
Yes, maybe.
It's not any surgery. Some surgeries do increase the risk of PID, but not any surgeries. Faith?
Multiple sexual partners.
Okay, and what do we mean when we say multiple sexual partners? So let's presume this lady had 3 sexual partners during her lifetime. Is it multiple sexual partners? Okay. Okay. Sarah? Do you have anything else?
ممكن early age of intercourse.
Okay, some do say early age of first sexual intercourse is a risk factor. Correct, Philip?
ممكن use of intrauterine contraceptive devices.
IHDs have a role, but not overall. And we'll discuss it slightly afterwards. Hassan?
Yes, doctor. ممكن الage يعني young age less than 30 مثلا. Her age كانت 28 فممكن الage. وكنت أحكي عن ال procedures. ممكن ال DNC حكينا عن ال DNC أو if she مثلا إذا any patient has endometrial biopsy ممكن يأثر على هاي الموضوع.
So any surgery during which you introduce an instrument to the endometrial cavity might increase the risk of PID. That is correct. So in general, if she had a new sexual partner in the past 3 months, that is a risk factor. If she was younger than 25, that is another risk factor. If she had more than 1 sexual partner over 6 months, and by that, that's the definition of multiple sexual partners or promiscuity. Promiscuous medically. When we say she's promiscuous medically, we mean more than 1 sexual partner over the past 6 months. If she has a previous history of sexually transmitted infection, she's 6 times more likely to have another one. If she had a recent IUCD insertion, so IUCDs per se do not increase the risk factor for PID in general, but recent insertion, especially if there is a subclinical infection, will introduce that infection to the endometrial cavity. So just over the 6 months after IUCD insertion, she's at increased risk. Any IVF procedure is a risk factor, termination of pregnancies, recent hysterosalpingograms, these are all risk factors for PID. Of course, the first 4 are the ones that are important for you guys as students, okay? Just disregard the rest, they're not quite important for you. So what should we do next? How should we manage this case? So as a summary, we have a 28-year-old lady who presents with chronic abdominal pain for 2 years associated with deep thrusting dyspareunia. The pain increases with cycles. She has slightly dysuria. Her uterus is fixed and tender. We found that she has pus cells in her high vaginal swab, and she was positive for chlamydia trachomatis on nucleic acid amplification test. What should we do? Samah?
We use antibiotic. Usually for chlamydia, we use doxycycline or erythromycin.
Okay. Hassan, do you have another suggestion? Or you...
Yes, دكتور نفس ما حكت زميلتي إنه anti microbial coverage نعمل لها. ممكن إذا كان مثلا عندها IUCD يعني مثلا حاطة IUCD ممكن we recommend يعني remove it يعني after that.
So far we agree that the ideal treatment is an antibiotic, but we disagree on the type of antibiotic. And we'll discuss it later on why the disagreement is. So far, is it cervicitis and vaginitis, or is it PID, our diagnosis? Hassan?
Doctor, it's PID.
Okay, so in PID, the treatment is not specific to the etiological factor per se. In PID, the treatment is always ceftriaxone, doxycycline, and metronidazole, all three together. Now, some books you'll see azithromycin and ceftriaxone only. I do accept both answers as correct. Why did we choose combination drugs? Because it's PID. And what are the causative agents of PID usually? The most commonly involved agent is usually chlamydia, then it's gonorrhea, but usually there's a multimicrobial component. There could be trichomonas, there could be mycoplasma, there could be Gardnerella vaginitis, there could be Porphytella, and all the normal anaerobes of the vagina. They could ascend and cause a PID. So usually for PID, the treatment is different than an isolated infection with chlamydia or gonorrhea, and we use a combination of ceftriaxone, doxycycline, and metronidazole. Is there anything else we should consider during our management of this lady? There are two other important aspects of management. Philip.
هسه considering إنه it was chronic, we might want to check إذا صار عندها tube ovarian abscess.
We did an ultrasound, if you remember.
Oh, yes.
We did an ultrasound before, and the ultrasound showed that the adnexia are adherent, but there are no adnexial masses.
Oh, okay.
And if there was a tube ovarian abscess, in general, in tube ovarian abscess, the patient will be toxic, or I'll show you an adnexial cyst on the ultrasound. Okay.
Then maybe ممكن إنه we have to make sure إنه ممكن to admit her till إنه if she was febrile till she's afebrile and make sure that she adheres to the medication.
Now, in general, there are certain indications to admit a patient. In general, if she fails treatment in the first place and we need to give her IV treatment, or if she's toxic or she has a tube ovarian abscess, then we might consider admission. But in general, we do not need to admit every single lady with PID. In parts of the world, PIDs are very common. Now, chlamydia, for instance, in the US, when they tested all the Army cadets for chlamydia, they found that 50% of Army cadets, female Army cadets younger than 25, had chlamydia, just chlamydia, disregarding gonorrhea and the rest. So it's quite common. So we can't admit 50% of our young women to the hospital just because they have chlamydia. So we should treat her partner, ideally with doxycycline, just oral doxycycline. Remember, the reservoir for chlamydia is usually the male partner, especially chlamydia and trichomonas. It's usually from the male partner. They'll cause subclinical urethritis in the male partner. And is there any other advice during our management? Hassan?
دكتور بيحكوا إنه لازم we consider retesting يعني after treatment for an infection.
Yes.
to report it كمان يمكن.
طبعا بس لأنه في دوشة كان تمام. We should do something we call test of cure. I'll discuss it briefly later on, but it's beyond your scope as students. But another more important aspect is abstinence. During our treatment, neither she nor her partner should be involved with any type of sexual intercourse. I'm saying any type. That means no vaginal, no anal, and no oral intercourse, even with barrier method, for the whole duration of treatment. Okay? And the last issue is what Hassan has discussed. It's something we call treatment test of cure, or TOC. Test of cure is testing the patient that she has been cured from the disease. This is beyond your scope. I wouldn't expect you guys to answer it, neither now nor next year. But in test of cure, after 2 to 5 weeks of finishing our treatment, our antimicrobial treatment, ideally we repeat the nucleic acid amplification test to confirm that the disease has been eradicated. Because it's very common for patients to have low compliance or have sexual intercourse during the duration of treatment, or even some, especially gonorrhea, has high likelihood of resistance if it's gonorrheal. So we should do a test of cure between 2 to 5 weeks after we finish our treatment. Okay? Is it clear so far? Okay, any questions? We're almost done.
يس دكتور تسمح لي.
تفضل.
دكتور بس انت حضرتك حكيت البيشنتس اللي عندهم PID في العاده بنعالجهم as outpatient يعني او بنعالجهم as outpatient.
Uncomplicated PID, yes.
يس هلا لما يكونوا inpatient بيختلف الريجيم اوف تريتمنت، يعني هل نستخدم شيء ثاني من اللي حكيت لنا عنه ولا نفسهم؟
لا نستخدم شيء ثاني، بس تسمح لي حسن بس نخلص. اذا لحالك بدك تسمعه بخليك لحالك تسمعه، بس هلا لانه اذا حكيته مع باقي زملائك راح ادوشهم زياده، وانا برايي ما فيش داعي يعني ندخلهم بهاي القصص حاليا، مش لمستواكم مع احترام يعني. فعشان بس ما نعقد الامور زياده، اوريدي معقد شوي زياده عن اللزوم. اوكي، فبس نخلص. اذا اللي حب يسمع شو راح احكي نحكي.
Yes.
Okay. Any other questions? Okay. So just one simple question: why did we not go with culture of the chlamydia or gonorrhea that we're suspecting, and we went for nucleic acid amplification test? Isn't culture the ideal diagnostic method for any bacterial infection? حسن؟
ممكن دكتور عشان يعني أسرع ومور سبيسيفيك التست اللي عملناه بتاع النيوكلير تيستينج.
Okay, so you sort of covered part of the answer. Yes, nucleic acid amplification test, because you're not trying to detect an alive bacterium, you're just trying to detect the evidence of presence of this bacterium. It's more sensitive, and because we culture, especially for chlamydia and gonorrhea, are very difficult, because chlamydia is obligate intracellular organism, so it needs a special kind of culture medium. The culture medium for it is embryos, egg embryos. And in regards to gonorrhea, it needs a special inhibitory culture medium with special antibiotics. And culture usually needs at least 5 to 10 days for these organisms, and they're not widely available. Not every lab that does any culture will culture for chlamydia and gonorrhea, and tuberculosis also sometimes. So we use nucleic acid amplification tests in these cases. And what are the other manifestations of chlamydia trachomatis? Does it cause other types of disease? And here we're talking about the same serotype that causes PID. Okay, Hassan, go ahead.
دكتور ممكن يعني as complication تاعتها ممكن تسوي arthritis أو.
Okay, so it's not complication per se of PID, it's a manifestation of it's one of the other diseases that are caused by chlamydia. So correct, it does cause arthritis. We call it reactive sexual arthritis or Reiter syndrome. Is there another type of disease? Philip?
أنا مش متأكد بس كأنه it increases the risk of ectopic pregnancy.
So that is a complication rather than a manifestation. And we'll discuss them in the next question. Yes, they do increase the risk of ectopic pregnancies. So in general, chlamydia, يزيد تفضل.
دكتور مش متأكد صراحة كثير من الجواب. إذا كانت حامل يمكن تسوي نيونيتال نمونيا أو نيونيتال كونجكتيفايتس أو شيء زي هيك.
Yes, that's one of the manifestations. That's the manifestations of vertical transmission. So not if she was pregnant, if she delivered vaginally and she had chlamydia, then the fetus or the baby will be at risk of neonatal conjunctivitis or neonatal pneumonitis. So in general, chlamydia can cause conjunctivitis in the adult, can cause reactive arthritis in the adult, along with gonorrhea. Both can cause something called Fitzhugh-Curtis syndrome, which is perihepatitis and inflammation of the area around the liver associated with adhesions usually. They can cause pharyngitis when involved with oral intercourse, proctitis, either by direct transmission through the mucosa of the vagina to the rectum, or sometimes with anal intercourse, especially in men who have sex with men, for instance. And then we have surgical transmission. It's vertical transmission. When we say vertical transmission in obstetrics, we mean that it's transmission during delivery. So it's not a congenital infection, it's vertical transmission. And in this case, vertical transmission to the fetus will either cause conjunctivitis or pneumonitis. And that's why sometimes in areas with high prevalence of these STIs, the neonatologist, what does the neonatologist do immediately after delivery, or the pediatrician, or sometimes the midwife? They will give the fetus erythromycin eye drops immediately after delivery, correct? To prevent these infections. Now, in regards to the other aspect of PID, are there any long-term sequelae of PID? Laith, if I remember correctly, said ectopic. Was it Laith or someone else? Anyhow, Sarah?
Doctor, maybe infertility.
Okay, so it could indeed cause infertility and ectopic. Is there something else these ladies are at risk of?
Doctor, tube ovarian abscess.
Tube ovarian abscess with chronic pelvic pain.
So tube ovarian abscess is an immediate complication. Usually it's apparent immediately with PID. It's usually the presenting complaint. But yes, indeed, tube ovarian abscess is a complication of PID, but it's not a long-term complication of PID. We're talking about years after PID here. Yazid?
Chronic pelvic pain.
Yes, chronic pelvic pain is another complication of PID. And would anyone care to tell me what do you mean? What's the definition of chronic pelvic pain? What do we mean when we say chronic pelvic pain? Sarah?
دكتور إنه بيكون pain for 6 months or more with menorrhagia maybe.
Okay, so chronic pelvic pain doesn't have other symptoms, just pain that's evident for at least 3 months of the last 6 months. If it's evident for at least 3 months of the last 6 months, we call it chronic pelvic pain. And chronic pelvic pain could be either due to interstitial cystitis, could be to chronic PID, could be secondary to endometriosis, pelvic congestion syndrome. But 1/3 of these cases are due to a very common non-gynecological cause. We'll see if anyone knows what's this very common non-gynecological cause. And that's the main reason why I asked about bloating, by the way, and the history. Okay, I'll give you hints about this cause. This cause is usually diagnosed via clinical criteria, and we don't need to do any investigations. The main mode of treatment of this syndrome is usually dietary support and maybe some spasmolytics.
دكتور ممكن تعيد السؤال لو سمحت؟
Okay. There is a very common syndrome that's not non-gynecological syndrome. That's very common in women. It's usually diagnosed clinically. We don't need to do any investigations. And it's treated by dietary support, and maybe we add some spasmolytics along with it. It's around 30% of cases of chronic pelvic pain and secondary dysmenorrhea are actually due to this syndrome rather than another significant pathology. Leif?
ممكن irritable bowel syndrome.
Yes, it is irritable bowel syndrome. So 1/3 of women with chronic pelvic pain or secondary dysmenorrhea would just have IBS. Don't answer it in your exam, just know it for your practical life. Okay? And how do we diagnose IBS? Does anyone know?
Clinically دكتور بدون investigations.
Yeah, how do we do that clinically?
إنه بيجي criteria 3 criteria: change in frequency in stool, consistency, and alternation between constipation, diarrhea.
So after you're done with this session, please try to go and read about ROM 3 criteria. That's the name of the criteria that's utilized to diagnose IBS. Okay? We discussed previously, just to remind you guys, that PID can be caused by gonorrhea, trichomonas, mycoplasma genitalium, Gardnerella, Provotella, and any of the vaginal microbes. So it's not just an STI. And that's why we usually use a combination of drugs to treat it. When do we need to test for chlamydia and gonorrhea? So in other words, do we have to test every single lady with a vaginal discharge for chlamydia and gonorrhea? Nucleic acid amplification tests usually are more expensive and more sensitive. And other than those, a positive diagnosis have social and psychological and psychosexual impacts on both the patient and her partner. So usually we don't have to test every single lady with a vaginal discharge for chlamydia. So when should we consider testing for gonorrhea and chlamydia? حسن؟
دكتور أهم يمكن إذا كانت عندها يعني medical disease، إذا كانت immunocompromised أو إذا إحنا بنعرف إنه البارتنر كان مع STI يمكن. بس mainly إذا في indications زي immunocompromised أو
we're not talking. Okay, sorry, I'm gonna cut you off just to specify. I'm not discussing screening, okay, or contact tracing. We're discussing a lady that's symptomatic with a vaginal discharge.
إذا كانت معناتها immunocompromised أو pregnant ممكن.
Okay, so in general, no, it's not in regards to immunocompromise or pregnancy. So if a lady had a new sexual partner in the last 3 months, along with this vaginal discharge, we have to test her because she's at increased risk. If she had any intermenstrual or postcoital bleeding, because these symptoms are associated with cervicitis and sexually transmitted infections, that's not vaginitis anymore. If it presents with abdominal pain, or we suspect that she might be having a PID, then we have to test her. And usually if she's younger than 25, we also have to test her. Okay? Just an image. If you saw this image in your exam, what's the diagnosis? Philip.
هي Fitz-Hugh-Curtis syndrome.
Yeah, that's an image of Fitz-Hugh-Curtis syndrome. That's a laparoscopic image. The lower aspect, that's the liver. Sorry. So that's the liver. That's the costal margin. And that's the anterior abdominal wall here. And these are just adhesions all around the liver. And that's how Fitzhugh-Curtis disease or syndrome is. So if you see a lady and they tell you she's having symptoms of PID, and you see this image, you should tell them that she's having either gonorrheal or chlamydial PID. Okay? That's a harder image. And I'll give you an additional hint. This lady had an IUCD. Here you'll see that's the uterus. These are engorged parametria. That's pus all around the patch of Douglas. And that's the rectum with the disseminated sulfur granules. Do you remember which polymorphic bacteria? That's associated with IUCDs, and it's usually presents with sulfur smell and sulfur granules. And it's named after a not very friendly country nearby.
دكتور في بكتيريا اسمها إسرائيلي something كان شيء زي هيك.
شو اسمها الأول بس؟ It's Actinomyces israeli. Yes. Correct. So Actinomyces israeli is a bacteria that might cause very chronic or a subacute PID. It's usually associated with IUCDs, and typically the hint will be sulfur granules. I wouldn't expect you to have it in our exams. For those of you who are applying for USMLE exams or PLABs, that's a very common question for them to ask you. So that should do it for today. As always, I try not to keep you more than an hour 15 minutes. So does anyone have any questions before we end our session? For those of you who don't have any questions, you're free to leave. Afi.